Yeah, thanks for having me. So I'm a pediatric dermatologist, and I'm going to follow the same vein of combination therapy for infantile hemangiomas that are early, so children less than 1 year of age, with pulse dye laser. I don't have a derma as much as I wish I did. Is it left? Not advancing. All right, so just to begin, so hemangiomas can be classified by their skin depth and their skin patterning. So they can be superficial, deep, or a combination of the two called mixed. And they are usually focal, so nice and round or oval, well demarcated, or they can be segmental, so more pattern like a port wine birthmark would be. Okay, and we know that some hemangiomas are at risk for permanent skin changes, particularly the superficial type. And if they stay nice and thin, they tend to heal great. But if they continue to proliferate, become nodular, more raised, they can leave permanent skin changes behind. Hemangiomas, by definition, are not fully present at birth. They appear sometime the first few days to weeks after birth. They grow rapidly, so the majority of growth is really complete by about 3 months of age. And what we're trying to avoid is the patient on the right? So the earlier we can treat within that first month or two, ideally, the better results we can achieve. Okay, so I'm going to give you all 3 clinical scenarios to take home, and the first one's the most straightforward. So this is a baby who has a thin superficial hemangioma, and you might say, well, this is going to do great regardless of what we do if this stays thin, and you are correct. But this would be a great candidate for combined treatment with topical timolol and pulse dye laser. Both those modalities work best when the hemangioma is very thin, like under 2 millimeters. This is the formulation of timolol I use. I like the gel-forming solution because it thickens on contact and it's easier to apply. I will mention that, timolol, has its limitations, and so 2 recent studies showed that it does help with erythema. It doesn't impact thickness to a significant degree in most patients, so that's where your PDL comes in. And just another reference to Rox Anderson's paper that remind ourselves that when we're treating hemangiomas early, our goal is really not to target vessels. We're really trying to induce regression. So in this situation, lower fluences, non-aggressive treatment is most effective. This baby has more of a raised mixed hemangioma, so you can see it's got a deep component here. At this point, it's really too thick for either PDL or timolol to be effective. So this is where we're talking about oral propranolol. I do, vast majority of my propranolol patients outpatient. It's pretty rare I would admit somebody for propranolol. I do a focused history. I do a heart rate because blood pressures in newborns are notoriously unreliable. I get an EKG only if there's something in the history that alerts me to do that, and an echo only if they have a large segmental facial hemangioma and I'm worried about face syndrome. That's the doses that I use. Main thing about propranolol, hypoglycemia, that's the main side effect, so make sure that baby's always feeding well. Make sure the baby feeds first, give the dose after. If they're not feeding well or at all, just hold propranolol, and you should be in good shape by doing that. 2 recent studies show that similar to timolol, propranolol also, even with using that, a significant number of children still have permanent skin changes at 5 years of age. And that may be because, propranolol wasn't given early enough. I think if it's given early, like the first month or 2 of life, it can be very, very effective. But my point is, there's still a role for laser in these patients once you get that superficial component thinned. Okay, last scenario is an infant with a superficial segmental hemangioma. And I want to point out something that's important. I think it can be really, really difficult to tell the difference between a port wine birthmark and a segmental hemangioma in a newborn. But the baby on the left, see how this is solid red, it's well demarcated. Baby on the right, it's more telangiectatic, it's lighter, it's less well defined, it's even got a little halo vasoconstriction at the border. So baby on the left is port wine birthmark, baby on the right is segmental hemangioma. And that's a really important distinction because your evaluation, your treatment approach is completely different between the two. Another thing about segmental hemangiomas I wanted to share with you all is they are highly prone to ulceration for a number of reasons, because they're large, they're extensive, they're on the face, and they may have face syndrome, meaning that they have abnormal vessels underlying that hemangioma that's providing less than optimal blood supply to the skin surface, so increased risk of ischemia. Let me just go back. And it can even happen ulceration congenitally. So this is a baby on the left who does not have cleft lip. That's actually in utero ulceration that occurred. One clinical tip I wanted to give you guys as far as ulceration is if you see this grayish white color change in a newborn or young infant, especially in a segmental hemangioma, that's not a good sign of involution. That's actually a sign of impending ischemia necrosis. So this is that same baby 2 weeks later. So be very, very careful with laser, with medical therapy as well in these patients. And along those lines, we've actually learned that with propranolol, if you have a situation where the hemangioma is ulcerating or looks like it's about to, you've got a white flag sign, you should use lower doses of propranolol, like 1/4 to 1/2 of what I would normally use. And that's because propranolol tips the scale between growth and involution pretty quickly. And if you do that too abruptly in a hemangioma that's already ulcerating, you can exacerbate that ulceration. This is a paper that came out in 2006, old paper, but showing severe laser complications that occurred from PDL after lasering segmental hemangiomas. But I think we've learned a lot since this paper, and I think, today a lot of these complications could have been avoided. So, for example, the baby on the left, you can see the white flag sign right. You can see it's already ulcerating. We would never laser that today. These babies were not on systemic therapy. There was no beta blockers then. It was 2006. We had no dynamic cooling on the lasers, and they were using fluences that were pretty high in these patients. So I've been really curious about whether we can treat segmental hemangiomas more safely now that we have propranolol. And the only study I've found that has really looked at this is Dr. Geronimus' study a little over 10 years ago. And he looked at infants treated with propranolol and then pulse dye laser within a month or a few months after versus babies that just got propranolol by themselves. And the babies with the combined therapy had better clinical outcomes and also required less propranolol overall. So I think it's a subject that's really interesting. Let's see, let me go back. One thing I would say is I'd still be very cautious with the segmental hemangioma, so I probably wouldn't laser a baby with a segmental until they're about 6 months of age and are really under really good control with propranolol. So there are risks and benefits you all of lasering hemangiomas early versus waiting until school age, and those are listed here. And I just want to thank all of my colleagues who love laser and vascular birthmarks like I do and have taught me so much. And thank you for being patient and coming back. I appreciate it.